I'm Laura Bonnell, and this is the Living with Cystic Fibrosis podcast coming to you from Detroit. Please subscribe and even rate and comment on our podcasts when it moves you. I learn something new with every podcast, and I'm always inspired by the people that are showcased here. We don't give medical advice. You need to connect with your doctor for that. I hope that this Living with Cystic Fibrosis podcast educates you and sparks some volunteering or advocacy. The CF community needs people like you. Thanks to our sponsors, Viatris and Vertex, for their support. Dr. Lumeng is the Frederick G.L. Huetwell Professor for the Cure and Prevention of Birth Defects, and he is also the Professor in Pediatrics and Molecular and Interactive Physiology. Dr. Lumeng is the Division Chief of Pediatric Pulmonology at CF Mott Children's Hospital and the Associate Director of the Michigan MSTP program. He grew up in Indiana and graduated from Princeton University in molecular biology, and he received his PhD in human genetics and MD from the University of Michigan and completed his residency training in pediatrics in the Boston Combined Pediatrics Residency Program at Boston Children's Hospital and Boston's Medical Center. He then completed fellowship training in pediatric pulmonology at the University of Michigan and started as a faculty member in 2006. He runs a research lab focused on the health effects of obesity and the links between metabolism and lung health, and the laboratory participates in both basic science and translational research projects in adult and pediatric obesity. He's funded by the NIH, YEA, and the CF Foundation for new projects studying the changing causes of diabetes in people with cystic fibrosis, which is really important. And he's going to talk about a number of things and mention one of his partners in crime at U of M, and that's Dr. Saba. He also has a grant, many grants from the CF Foundation, and he has so much to talk about with us. We're glad to have him. He is also the recipient of a fellowship program that the Bonnell Foundation funds. So we're glad to have him. He is also a supporter of the Bonnell Foundation, coming to our events as well and spreads the word about what we do. So it's going to be a wonderful chat and great podcast. Well, thank you again. It's great to see you, Dr. Lumeng, as always, and everybody's going to learn a lot of really interesting information in this podcast. So welcome.
Thanks, Laura. Thanks so much for having me.
As I mentioned in the introduction, we have a fellowship program that was started a couple years ago by the Bonnell Foundation for University of Michigan doctors. And can you give us an overview about what that is, what it means?
Yeah, so we have a set of trainees that we are training to become pediatric pulmonologists, right? So for all CF patients, they are followed and cared for by board-certified pediatric pulmonologists. So typically the path is after finishing medical school, trainees will do a residency in general pediatrics where they learn how to do all of pediatric care. But then if they want to become a lung doctor and treat patients with CF, they would do a 3-year fellowship in pediatric pulmonology. And ours is one of, I think, 2 programs in the state of Michigan. There are training programs throughout the United States. And we currently have 3 pediatric pulmonary fellows in our program that are trained to become pediatric pulmonologists. What that usually entails is that they spend the first year really intensely doing clinical work. And then the next 2 years, they do clinical work as well, but they also do a scholarly project. And related to an area of their interests, it can be asthma, it can be basic science research in a lab, or it can be cystic fibrosis. And really, it's the time when the fellows are exposed to lots of different areas, and if they're interested in CF research, they will then embark on a scholarly project mentored by one of our numerous faculty at the University of Michigan. So the benefits of the fellowship is that, we certainly have resources to help with their training, but sometimes there are gaps. Like sometimes we're not able to pay for, let's say, courses they'd like to learn to become more adept at learning statistical methods, or maybe they need some resources to complete a research project in the lab by using one of our various mentors. And that's the gaps that where the fellowship started by the Bonnell Foundation can help. It will help directly with the fellowship training to help them gain the skills to become a board-certified pediatric pulmonologist and go out and then treat patients or contribute to cystic fibrosis research. We have a pretty good track record of getting research funding from the CF Foundation and other sources like the National Institutes of Health to support research at the University of Michigan. And we provide that platform to our fellows if they're so interested in terms of that. One exciting development that also expands the opportunities is that recently we've had a lot of number of researchers at U of M that have been interested in CF research and really coming from different angles, right? So certainly I have a small CF Foundation grant that I'll talk a little bit about on CF-related diabetes. Dr. Lindsay Caverly works on the microbiome and basically how the different bacteria interact within the lungs of patients with CF. But we also have people in engineering, for example, that are designing, engineers are really good about making widgets. They can make little devices, but are asking, well, what can we then apply that to, and what problem can we apply it to? And we have, many of them have seen CF as an opportunity to apply their little widget to that question. Or a faculty member in pharmacology, for example, who is studying different ways to get drugs into drug delivery for either for microbacteria or for treating CF. Or to one of my lab neighbors, actually, Jason Spence, who is fundamentally working on how do all the cells in the lung interact over development and how might that be different in patients with CF. And so he's working on that as well. So because we had a kind of a base of researchers here that I think we all knew each other peripherally, but never really coalesced, we got a small grant from the CF Foundation to develop a program for what's called a Cystic Fibrosis Research Development Program, and where we're trying to develop the kind of a research center where we all meet. So we've been actually meeting on a monthly basis. We've had a couple of symposia where we all present our work and ideas and share different ideas. And so that's going to be a rich opportunity for the clinical fellows as well as a large number of other graduate students and postdocs to learn more about CF research. And so, again, there's some gaps often in their need for a little bit of reagents here or there, or to attend a conference to learn more about these techniques. And that's what this fellowship can provide as well.
And it's so wonderful, the collaboration. As we all know, brainstorming for anything is really important because it makes you think about other things. And all that you just mentioned is really important because I think you can say, hey, I'm working on this. That might connect with this. And then you're exciting the new people that are coming into the field and they're seeing the possibility and how your brains work and that you're thinking about more that you can do. That's, even though I don't understand nearly to any extent that you understand science, it's so exciting to just to hear you talk about the whole thought process and all the grants and everything you're doing. And we've been around for a while, but it is still, to me, and I want to hear what you think, it is still so exciting about science and where it's taking us in the disease world.
Yeah, absolutely. I mean, I think that's the fun part about science. I mean, I'd equated a lot of things that you do. You have certain knowledge and connections to different people, and you view it from one lens. But there are other people who view it from a different lens, right? So an engineer who built something, say, I'm really good at building this little widget, but I don't know what I can apply it to. And then when we meet together and sit in a room, say, hey, you know what? Here's a problem that your little widget can solve. Maybe we can work together and try to figure that out. And I think that's been a strength at Michigan for quite a while. Everybody's kind of in their one little focused area where they do. But by bringing everybody into the room, we can think, well, gosh, if we paired these two people together and built upon what they're both good at, could we get something, new done? Now, the reality is, none of us are twiddling our thumbs without working, with extra time to work. So that's where these fellowship opportunities come in, where we can say, hey, here's a trainee who would love to learn some of these new ideas or new techniques, or has a question, let's say around CF-related diabetes or CF new ways to analyze lung disease such as MRI, and can we work together, have this training work on that problem, and work between us with kind of co-mentorships, and that's largely the way we've worked. That was the way I trained as during my fellowship. So I did my fellowship here as well, and for my research part of it, I knew I would probably fit between a couple of areas. When I was growing up as a trainee, childhood obesity was growing up, pretty rampant. But, it was interesting to see patients with CF-related diabetes where you wonder, gosh, well, why is their lung function going down? And sometimes we then find, well, they're developing diabetes. So the question is, why is that happening? Why is there a relationship between, your metabolism, your body weight, and lung function, which is a really, really common thing. And so that kind of got me thinking about, well, where can I get mentorship to think about these different issues?
And I was going to say, talking about cystic fibrosis and obesity is something we would have never thought about even 30 years ago, because for anyone that doesn't know, if you have CF, usually you're categorized before diagnosis as a failure to thrive, right? You're so skinny, you can't gain weight. It's so hard. Even for one of the girls, it was so hard. We were like, eat more, and it was always like, throw in butter, throw in high fat, throw in everything, because they couldn't gain weight. And now with the new modulators, it's easier. So that's why you're doing research and we're talking about CF and obesity, which is a new mindset for people. It's a whole other thing. It's okay for some people. Some people are with CF are freaked out about it. Like, wait a minute, now I have to worry about my weight. So take us through, like you were just starting to talk about, how this got started and why you're doing this research.
Yeah. So, one of the funny things I just related to what you're saying is, I became basically interested in why is obesity bad for your health? This is one of these overall questions that we're trying to understand. Certainly, having too much adipose tissue, or fat tissue, we call it, is a problem, but also having too little is a problem too, right? That's what mainly people are combating in patients with CF. And even by beginning of training, when we didn't have newborn screening, the vast majority of patients were identified because as an infant or toddler, they just would not gain weight. And that had lots of health effects. So too much is a problem. Too little is a problem. What is it about the adipose tissue or the fat tissue that is important in health is kind of where I got. But the funny thing I was going to say is, so, I'm a basic science researcher. So when we think about a problem, can we model the disease in some way? Our lab works with laboratory mice because we can keep them around a cage and we can do different things to them and study. And if you put them on a high-fat diet, so we actually feed our mice a diet that's 60% fat, so it's kind of like eating McDonald's every day. It's actually, in many ways, the only clinical scenario I can think about that's very similar is CF, when you are putting fat and butter and Scandi shakes, all these other supplements. It's kind of one of the few models where it really, CF is one of the situations where we do actually feed people a high-fat diet. We're always often criticized, well, nobody ever eats that. But actually, patients with CF at some time in their life have been told, hey, you need to eat more fat calories. So these mice get obese very quickly. They also get diabetes, and we can study then how that diabetes developed, how we can potentially cure it. We can do weight loss models and a variety of things that we can study in a laboratory mouse that we can't do on scale in people. So that's really what my interest became, is this overall question of why is having excess adipose tissue or too little adipose tissue a problem in health? I actually thought I was going to attack this from an asthma angle because, as you said, back then, obesity was never thought about. But lo and behold, in the last 5 years, the number of patients with CF who are obese or overweight is going way, way up, which I think is for good reasons. But now we're wondering, well, is the type of diabetes they're having a little bit different, right? So it used to be, I think there's still lots of unknowns about CF-related diabetes and how it works. It's certainly a mixture of the pancreas, which is what makes the insulin in your body not functioning as well. And so that's largely been where all the research in CF is really focused on, is how can we make the insulin-producing cells work better. But one of the problems when you have too much adipose tissue is that the insulin doesn't work as well. People might call it type 2 diabetes, but it's a different type of way to think about it. And that honestly is the core of what my lab is focused on is how does type 2 diabetes develop. And so now my words have come together, right? Initially, obesity was over here and CF was over here, but now they've kind of merged together. So we have a small pilot grant from the CF Foundation where we're actually taking the mice who are not deficient for cystic fibrosis, TR, the gene for CF, putting them on high-fat diets, studying their metabolism, actually studying their inflammation, because now we think that inflammation is a part of why the diabetes develops in obesity. So we're basically trying to build new inroads into why is this happening. Our new treatments that we're using for type 2 diabetes, such as these new GLP-1 medicines, people might have heard of Wegovy and all these things that are on all the rage now, are those good treatments for patients with cystic fibrosis and with a little bit overweight and obese, or are they going to cause problems down the road? And so those are things that I think are going to be maybe the new wave. But it's a great place to be, right? It used to be, we were talking a ton about, there are so many of my patients who were teenagers. You had to have a difficult conversation about a G-tube placement, right, to get their calories up if they can't do it on their own. Largely, those discussions are fewer and fewer right now, which is an excellent place to be. But now that we're in it for the long term, right, we're in this for well over 5 to 6 decades. We have to ask the question, well, are we setting them up the best for their long-term health? And part of that is weight control and making sure we don't push them too far in the other direction.
And what have you found so far? What have you learned? Because, yeah, it is very interesting. How does it help, hurt, change people's lives?
Yeah. So we're still in the early stages. I think one of the things we're thinking about it that's different than what different way to think about it is, everybody's focused on where the CFTR, that CF transmembrane receptor gene that's defective in CF, how it functions in the lung cells, because obviously that's one of the most important places. However, we know it's relevant in other places, right? It's expressed in cells in your GI system, in your gastrointestinal system, which is why the pancreas has issues. We've actually already also found it to be expressed in macrophages, which are inflammatory cells. So the question is, why is it in macrophages? And maybe is there something different about the macrophages of a patient with CF or a mouse with CF versus not? And that's been studied in the context of lung inflammation. We're actually studying that in the context of obesity. And the other finding we've actually found is the fat cells themselves. So these adipocytes, which are part of your adipose tissue and your fat cells, those actually make a lot of CFTR as well. And so we're trying to study maybe there's something different about the fat cells of people with CF that may also modulate their metabolism. So right now we're dissecting really piece by piece, thinking about it not just as, gosh, this is a lung problem, but maybe there are important roles for the CFTR in inflammatory cells that may be linked to the lung disease, but also in the metabolic cells themselves. And that, again, normally you wouldn't push those cells to do anything different. But now with when they expand and with overweight and obesity, they may be challenged to do things they're not very good at.
And I'm also wondering, because I've heard a little bit about this, I'm wondering if CF patients are seeing endocrinologists more in addition to diabetes. Is it like, would it be hypoglycemia? Is that also playing a part in, what's happening?
Absolutely. So, besides training more pediatric pulmonary people, we need to train more pediatric endocrinologists who are expertise in CF-related diabetes. And there's a big need. There's been many papers and focus areas of the CF Foundation on developing more people to understand CF-related diabetes because it's more and more of an issue. So at Michigan, we're fortunate enough to have one of our pediatric endocrinologists, Dr. Henney, who has a particular interest in CF-related diabetes and is funded by a small CF Foundation grant. We also have adult endocrinologists because majority of these problems actually start coming up when they transition beyond 21, and she also has an interest in CF-related diabetes. So at Michigan, we're fortunate to have people with an interest in this question and this ways to manage it. This also goes back to the fellowship. So one of our current fellows, she's trying to develop her research idea, and she's latched into maybe thinking about wanting to understand CF-related diabetes more, so that we have a great collaborative environment between a pulmonologist, endocrinologist to think about it holistically and bring along there. So yeah, and diabetes, which is too high a blood sugar, right? and ways to keep it down is something that, even though we were, as pulmonologists, we know about, we're not trained in all the latest treatments for. So that's where we really need the specialists like the endocrinologist to help.
And I think it's interesting too, because people with cystic fibrosis are becoming real athletes. I mean, they're in races, their muscle to fat is really high, they're working out. We could name so many. I think Sophia Holmes and, Emily Schaller and so many people that are really working hard. So you have a lot to work with and a lot of different levels of CF and how people are staying fit.
Yep, and that's always important, right, as part of it. So, our goal as pulmonologists and as pediatricians is let people do is everything they can do and function at their highest level they can potentially. And thank goodness we're at a stage where, for the most part, the patients that I work with who are competitive in whatever it is, archery, if it's, running or all those things, are able to compete at their nexus, at their peak potential. And often that's very motivating for them as well, which is good, right? So it gives them something as a goal to set for. And I think that can help. Often we put, there are all these challenges of using all the medications that we have, but I like to put it in the context like, look, if you really are excited about being the best gymnast you can or being the best, track runner you can, these are part of the deal for you to really be at peak level in practice. So yeah, absolutely, that's a key part of what we do and how we work with people.
And one thing I always like to point out is this research that you're doing, this research about CF and diabetes, no research is ever just about one disease. What you find out will benefit maybe parents who are caregivers who have weight issues. Or, that's been my whole life. So it will go into other diseases. It will go into, you'll just have so much information. And that's what I love about science and innovation and research, because everyone's going to learn from what you find, correct?
Yeah, absolutely. And that's why, in many ways, the CF work is a bit of an offshoot of what we're mainly working on, which is, this, as I said before, why is adipose tissue bad for you? We certainly know for some, we think about the bouncing baby, and you like to see them a little bit. Adipose tissue in a baby actually is very good for a baby, but too much can be a problem. So there are several things that we're working on that are related to this, and it's all collaborative, which is fun. So one of them is we have abilities now to identify every single cell type in adipose tissue, and that's been a mystery for a long time. We were doing that in adult patients. So one of my collaborators is an adult bariatric surgeon. So he will bring back big pieces of adipose tissue from surgery so we can study them and try to identify all the cells. And we're just finishing and completing analysis of what we're hoping to be is a developmental atlas of adipose tissue. So in collaboration with our surgeons at Mott Hospital, both general surgery and cardiac surgery, we have adipose tissue biopsies from infants, from toddlers, from school-age kids, and adolescents. So then we think we can make a map of development of adipose tissue so that we can then understand, well, how might it change a different disease context? How are there new cells we have to think about? Are there new things that we can assess either in the CF patients that are challenged with growth or those who have excess growth as well? So fortunately, there are lots of people working on the obesity problem at Michigan, and so we have a lot of people to collaborate with as well.
And I don't know if this is going too far out, but could it also help when they do cancer research about, people who are more prone to cancer because they're obese? Or
it links a lot of those things together, and the other obviously it links in is nutrition, the nutritional aspects of it, right? So every patient with CF in our center and others are seen by a dietitian, and so we work alongside of them to kind of the ideas being what are the best treatments or dietitian ways to kind of put everything together. So it is one of those very collaborative efforts that we go through, but we're still, and most of the people are interested in the why. And we know that there's, for some reason, some people have healthy adipose tissue. Other people don't have healthy adipose tissue. There's adipose tissue found everywhere in the body, right? So even behind your eyeball, in your bones, in your cheeks, right? In your buttocks. storing energy in some places is actually good for you, and in other places it's bad for you. And so we're trying to understand that as well.
Yeah, and we all lose weight differently.
Yep.
I mean, there's so many different variables, and it seems like women have a harder time than men. I don't know. But did you say how long the study is and kind of what, I mean, I know you don't know what you're going to find, but what are you hoping to find when it's all over?
Yeah, right now, so we're still in the middle of completing a couple of analyses, but we're hoping to sort out these issues about is CFTR in some of these other cells, like a macrophage or a fat cell, somehow contributing to the diabetic phenotype. So again, we can, in the mice, we can measure diabetes and do, you remember during your pregnancy doing a glucose tolerance test where you drink glucose and they have to get your blood drawn. All our patients with CF know about this, right? So all of our patients with CF get a glucose tolerance test on a regular basis or should through their CF center. And we can do the same thing in mice to assess, well, as we make this either genetic change or treatment change, does their diabetes get worse or better? And so we can do this in a very controlled setting that gives us control over a lot of different variables without having to put a bunch of patients at risk, and we can do them in mice to learn that. So that's, we call it basic science research because we're able to ask questions and answer them fairly quickly to hopefully point a direction as a way to go for treatments.
Well, it's really interesting, and I can't wait to hear about what you find and what you learned and how you'll use it in the future. There was a lot going on in science and a lot of concern about the future for science and research. How are you feeling about, where science is going and where things are hopefully headed, that, all this research will continue and you'll have access as doctors?
So certainly as of this recording in mid-February 2025, there's been a lot of discussion. There always should be. This happens every 5 or 10 years, in my experience, of the role of the NIH in funding research, and are they doing a good job of shepherding the funds and all that stuff. So I think that's really what I'm focused on now, and to make sure all your listeners think about. There are a couple of things that are being actively talked about over the last month. One is a pause in all the funding to the NIH, which has been temporarily lifted. But the second is cuts to these facilities administrative fees that have been discussed as well. Let me point out a couple things for the audience as they think about these issues from my perspective. First of all, the research at U of M funded by the NIH for research on cystic fibrosis is about $3.2 million a year. So we have actively lots of money from the NIH coming to Michigan to answer these questions about cystic fibrosis. This involves developing new animal models like rabbit models for CF, looking into new ways to do gene editing that can be the next level of treatments for CF, identifying new cells in the lung that can explain the complications of CF in the lung. Those are all funded by the NIH. So this idea that there's not much funding for CF research from the NIH is not true, especially for Michigan. So any pause in funding will have direct effects on that. For example, Dr. Elizabeth Caverly is part of a study where they are trying to find new treatments for bacteria in the lungs that are resistant to lots of different antibacterials. There's a new treatment therapy called bacteriophages, which is a new type of treatment for these bacteria. Think about it like a virus that instead of attacking the person, attacks the bacteria. There's an active clinical trial. We've already recruited patients for it. So this pause in federal funding put all those patients at risk for not getting the therapies that they're currently getting. So that's one major implication of these wholesale stoppages. We don't think it's fair to the patients who've already identified, joined the study in the middle of being a treatment. We have to monitor for safety. We have to monitor those things. I don't think it's fair to them. It's certainly not great to the researchers, but it's really not fair to the patients to halt what we're doing for them in that context. So that's one thing that's at risk for that. The second thing is these thoughts about these facilities administrative costs that they're trying to cap a little bit.
You're talking about the indirect costs, the 15%, yeah.
Yep. So there are different ways. There's going to be a lot of discussion on what it's called, but I think indirect is probably not the best way to do it. I think there really is, because it really is paying for facilities, and and administrative, but really more for the facilities. The way I think about that is when I put a budget together to the NIH, I pay for my people, I pay for the equipment, or I don't pay for the equipment, I pay for the reagents to do things. I can't put money to pay for the lights, for the heat, for the water, for the regulatory issues to keep patients safe if we do any patient studies, the equipment to run the lab. All of those are part of that facility's administrative costs. We run mouse studies, so a lot of those mice have to be taken care of by veterinarians to make sure the mice are safe and we're doing ethically. And all of those are being paid for by these facilities' administrative or so-called indirect costs. So the idea that when they make this cut, they're not cutting research is not true. They are dramatically cutting the investment in research. So again, the estimate at University of Michigan is about $181 million at risk.
Wow.
This is not just for Michigan. Michigan State, Wayne State, Henry Ford are all at risk for losing quite a bit of money that supports these other things. The analogy, I like analogy for a lot of things. So you might imagine if you bought a cup of coffee, if we only charged you for the beans, the water, and the person's time, you might imagine that's the direct cost for the grant. I don't think anybody thinks when we pay for a cup of coffee, we're only paying for that. So whatever all the other costs go into buying the machine to make the coffee for the first place, making sure the water quality is safe, making sure that it's a heated area and that you have light, make sure that you can get your coffee through a drive-through appropriately, and making sure that all the lights stay on. Those are all these, facilities administrative costs that let you get that cup of coffee. And they're not funding research. They're actually pretty fundamental to what we're doing. It's not paying for future advances, but it's paying for what we've already invested in that project to keep this project going. So those are the things that we think about. And the other thing I point out is this indirect cost rate or this facilities rate that they're mentioning has not really changed for about 30 years. So it's not like we've been adding more and more to the pie. Actually, none of the grants that I've applied for in the last 20 some years have changed for inflation at all. So we're trying to do more and more with less. The other thing I'd point out is that we are not alone in this concern. So the CF Foundation, I think very recently put out an email and a statement that they feel that this is really, really important as well. They understand that these facilities administrative costs are a key part of research and the way they're doing them, and that a cut to them is a cut to funding.
Yeah, and the bottom line is the people we love, or even ourselves, which we also love, but it can impact a future disease that we will have. Like there is absolutely, we wouldn't have the cure for sickle cell if we didn't figure out some things in cystic fibrosis. Like everything is related. So
yep, everything's related, and that's where a lot of these facilities costs come into. So, for example, in our lab and other labs here, we use these equipment that costs millions of dollars. I could never buy it myself because I don't use it enough. But if you put enough people together, you can buy a very valuable piece of machine that elevates everybody's work with that. And that's where these facilities administrative costs go to make sure the facilities we can do cutting edge research, we can all use the shared research together and make optimal use and get the information as quickly as possible.
I love the way you broke it down to coffee because I think everybody can relate to that. So thanks for explaining it on many levels. And you're doing so much. We could definitely do this podcast all day and just be beginning to understand all that you're doing and what you're working on. But what else did you want to mention during the podcast about what you're working on or the hopes for the future of cystic fibrosis?
Yeah, so I think for our CF Center, we are still always expanding and hoping to, make sure we do the best job as possible for everybody in the state of Michigan. We understand it's a challenge, right? We've been reviewing where our patients come from. They come from all over the state. So we are trying to do as good as we can to expand to make sure we can capture as many patients as possible to provide resources for those who aren't in Southeast Michigan. We were reviewing our information, and a lot number of patients travel over 50 to 100 miles to come see us, and we want to make sure we can attune to all that as much as possible, and also give them the best experience as possible, and if possible, get closer to them. So those are the things that we're working on. We've recently applied for a a grant for us to train more of our trainees. So again, we know that as physicians, we can't do it all. So we need more dietitians to know about CF and CF-related diabetes. We need more social workers who can understand all the complex navigation of the insurance system with all the new modulators. We need pharmacists to kind of learn about the new medications, know about how we can adjust them, make the right choice, and also monitor for side effects, because these are fairly new medicines, as well as nurses who are a key part of our workforce and can help expand our care elsewhere. So we've been applying for a grant that can support more trainees for that. Certainly as patients, with CF come into our clinics, they will meet residents and the physician trainees. We don't have as many of these other trainees that come into our fold, and so we're hoping to build that so that we have a bigger training base. Michigan's fortunate because we have a great school of social work, we have a school of nursing, we have a great school of dietetics and the school of public health, and we have a great school of pharmacy, and we want to leverage all those pieces to bring more trainees here. So that's one thing we're hoping. I'm happy to come back and give you an update about how that's going to look. But we think that will benefit everyone, right? Because as certainly as a mom, that while the doctors know a certain amount of, it takes a team effort, and we have a great team that we're working with, but we need to build more of those people, right, to serve not just our group, but also the state of Michigan in general. And so we're hoping to do that.
Well, it's wonderful. And to anybody listening who's thinking about becoming a doctor, a social worker, a nurse, whatever it is, get involved, because we definitely need more people in science.
Right. And it's really, it's science, but it's also care. And, there are different needs for different populations. For those who enjoy working with children and with families, navigating these things, the idea being that there are multiple paths that you can take to be involved in children with special health care needs, and that take advantage of everybody's skill. And it kind of circles back to what we talked about before, where I think it's fun where, I learn things every day from our social workers, but hey, about this program they didn't know existed, or the pharmacists say, hey, we have these new medicines coming in the pipeline. Here's what we have to worry about for monitoring all those things. So it really is a team of experts that kind of come together. Not everybody understands everything, so everybody can contribute to the pie.
Well, thank you for sharing your excitement about all things CF and for what you're doing. It is really exciting and interesting, and I can't wait to hear how all your studies and research go. So thanks for, filling us in.
Yeah, absolutely. And I'm happy to answer your questions from the audience, and I'm happy to also come back and give you an update in 6 months and how things are progressing.
Perfect.
Okay.
The original music in this podcast is performed by Kevin Allen.
It's not complicated.
Who happens to have cystic fibrosis.
We all got our worries and fears. I know what's got you frustrated, but loving you is so alright.
This has been the Living with Cystic Fibrosis podcast. For more information and to learn more about the Bonnell Foundation, visit our website at thebonnellfoundation.org. That's the BONNELL Foundation.org. This podcast was sponsored by Vertex Pharmaceutical, The Science of Possibility, and Viatris. It was produced by Jag and Detroit Podcasts. Follow our show in Apple Podcasts, Spotify, or wherever you're listening right now.